This program is brought to you by Stanford University.
So we're going to talk about irritable bowel syndrome. What I'm not going to spend a lot of time today, and perhaps we can leave it for the question and answer session, is aspects of treatment. What I thought we'd focus on are some newer developments in the pathogenesis, i.e. what causes irritable bowel syndrome. So as most of you know, irritable bowel syndrome is defined on the basis of symptoms, and these are chronic and recurrent, typically more than 6 months, and often several years, if not the lifetime of the patient. And the typical symptoms are lower abdominal pain or discomfort, coupled with altered bowel function. And mysteriously, this alteration in bowel function can either be constipation or diarrhea, and even more mysteriously in the same patient, be both. The third symptom that we're not going to spend a lot of time on, but will allude to in my lecture, is bloating. And the key feature of irritable bowel syndrome is that it is not explained by identifiable structural or biochemical abnormalities, at least to the extent that our current tools allow us to do that kind of assessment. So what is the impact of IBS on our system? It's tremendous. It's a very highly prevalent disease. The annual cost of the disease is estimated as over $30 billion per year. And if you poll gastroenterologists, they will tell you a third to up to a half of their patients have some variation of irritable bowel syndrome or related disorders. Even in primary care, up to 10% or 12% of patients will meet all the criteria for irritable bowel syndrome. And I won't get into this, but several surveys have shown that IBS, or irritable bowel syndrome, is associated with a reduced quality of life to the same extent as some of the more classical disorders that are associated with inflammation as ulcerative colitis. So it's a significant problem. And again, this slide just shows you the major symptoms of IBS in females, because this is a disease that predominantly affects females, at least in the Western world. And these are abdominal pain in 35 to 40% of patients, urgency, the desire to get to the bathroom as fast as possible, often associated with discomfort and pain, and bloating. And again, just to recap, if you do get a biopsy from a patient with irritable bowel syndrome, you get a biopsy from the colon, or if the patient has surgery, you can get the whole colon, and you can examine it very carefully. You can go over it with your pathologist, and typically the reading will be normal. So then some of the questions that I often get asked is, Doc, if the gut looks normal, why do I feel so bad? And there's a perception out there in the literature as well as in the community that this is a spastic condition. This often has been referred to in the past as spastic colon, so people say maybe it's my gut that's going into spasm. So let's examine that a little more critically. This is an older study I done a couple of decades ago that examined the pressure in the rectum of patients after they ate a meal. And what they found was that, in fact, patients with IBS, represented by this red curve, do have a greater contraction of their rectum after they eat a meal compared to normals. And this, at least in some patients, may explain the desire to go to the bathroom and have a bowel movement shortly after a meal, regardless of what the meal contains. However, such contractions of the bowel are very common, both in patients as well as in normal subjects, and often not associated with any symptoms. So the correlation between the symptoms that patients with IBS have, mainly pain, and these contractions is very, very limited. So we really can't conclude that spasms are the cause of these symptoms, particularly as the response to common antispasmodics is very variable. So then, if the gut looks normal, it's not in spasm, is it all in the head? And this is really the heart of the talk today, and I'm going to go into this in some great depth. So let's examine the first question. Is it all in the head, and how we typically view that question? In other words, is this all psychological? And this has been extensively studied in patients with irritable bowel syndrome. So I'm summarizing here on this slide 3 studies from 3 different cities. If you look at the percentage of psychiatric disorders in patients with irritable bowel syndrome shown in the red, this is much higher than patients with other GI disorders, the so-called organic GI problems, or even normals. But you just can't take those studies at face value. One of the things you need to know is that most people who have irritable bowel syndrome don't go to see a doctor. And this is kind of the pyramid of care that we have with irritable bowel syndrome. Only 25% of people who satisfy all the clinical criteria for IBS actually, only 25% actually go see a doctor. The other 75% stay at home, suffer silently, try home remedies. So what we're really interested in is not that 25%, but the entire population. And if you look then at the same question, at the psychological findings in IBS patients, defined as those people with IBS who seek health care, versus IBS non-patients, those people with IBS who don't seek health care, you'll find that it's only in the patients who seek health care that there's a higher incidence of these psychological abnormalities. So people who have irritable bowel syndrome and don't necessarily seek health care are equivalent to normals in terms of their psychological profiles or the prevalence of psychological disorders. So what does this mean? Well, we know a significant number of patients with irritable bowel syndrome have anxiety or depressive disorder, but so do a significant number of patients with any chronic disorder. Chronic pain of any kind, whether it's chronic arthritis, will and has been shown to result in anxiety or depression. So it's unlikely that IBS is caused by anxiety or depression. It's true, as I've shown, that psychological factors may drive excessive healthcare seeking behavior, but this may be simply because these are the patients who also have more severe disease and are more likely to have depression and anxiety. Only a very small fraction of patients will have so-called hypochondriasis and somatization. I emphasize this because even a lot of my colleagues, physicians, particularly those who don't take care of irritable bowel syndrome, will dismiss these patients as psychological and refuse to take care of their symptoms. So I'm showing this cartoon because I want to now switch gears a little bit and talk about the other brain in our body. So when I was young, my mother frequently used to scold me and tell me I didn't have any brain at all. So when I grew up and became a gastroenterologist, I was very glad to prove her wrong. In fact, I told her I don't have just one brain, I have 2. So where is the other brain? See, the other brain is in the gut, and it lies just beneath the surface. So on the left-hand side here is an endoscopic view, many of you have seen this, of the surface of the lining of the esophagus or the stomach. But if you scratch that lining and look just beneath, what you're going to find is this other brain. This is a collection of nerve cells that is entirely contained in the wall of the gastrointestinal tract from the esophagus down to the rectum. This is a brain in itself. It's autonomous. It does not require the big brain in our skulls to work, and it handles the GI tract very efficiently, very smoothly, so that in most people, most normal people, you're unaware of the complex coordination of either contractions or secretions that are taking place in order to digest your food. This brain is called the enteric nervous system as opposed to the central nervous system, which is the brain in the skull or in the vertebral column, the spinal cord. And this is a complex structure. It doesn't look like the brain in our skulls, but it is equally complicated. And shown here are some of the elements that comprise this brain. These are the nerves that control the muscles. And the nerves are of several different types. They can be inhibitory or they can be excitatory. The muscles by themselves need a third type of cell to contract. That's shown in green, and that's the interstitial cell. So it's really a very complicated system, And it's not simply a question of turning one nerve on or turning a muscle on. It's a very complex interplay of all these three cellular elements in order to get a good contraction. On top of this image is an en face view of what these nerves look like, what this enteric nervous system really looks like. In fact, this nervous system is the oldest nervous system from an evolutionary perspective, has more nerve cells than the spinal cord, estimated about 100 million or more, and has been a rich source of discovery. Most people don't know, for instance, that 95% of the serotonin in the body is contained in the gut and not in this brain. In addition to serotonin, it has many other neurotransmitters, such as dopamine. Again, the gut is a very rich source of dopamine. So how does this brain work? As shown in this cartoon is what happens typically when you swallow food and it reaches your gut. Food in the lumen of the gut, in the hollow central part of the gut, stimulates a particular kind of cell called the EC cell that lines the gut to produce serotonin. 5-HT is a short form for serotonin. Serotonin then stimulates nerves lying just beneath the epithelium, just beneath the lining, and this initiates a chain of events that results in contraction of the gut behind the food and relaxation, this is an active process too, of the gut ahead of it. So now you have a pressure head that pushes that food forward. So this is really what we call the peristaltic reflex, but it's a very important component of movement in the gut. And as I mentioned, 5-HT or serotonin appears to play a key role in the initiation of this reflex. It not only is important for the reflex, however, this chemical, serotonin, plays many other important roles in the gut. It can stimulate the lining of the gut to produce fluid, a process called secretion, but it can also stimulate nerves in the gut to produce either pain or nausea. So we now know that perhaps this chemical is altered in some patients, at least, with irritable bowel syndrome. And the subgroup of patients that we found the most evidence for alteration in this chemical is the subgroup that we call post-infectious irritable bowel syndrome. And shown here on this slide are two sections, one on the left from a normal subject, and you can see that the serotonin-containing cells are actually are not that dramatically increased compared to this patient with irritable bowel syndrome, where there is a great deal more serotonin. So in the post-infectious kind of irritable bowel syndrome, which is about 10 or 20% of patients, you may have evidence of increased levels of this chemical, and with all the effects that I've shown you in terms of stimulation of peristalsis, induction of pain, this could help explain in part how the symptoms are produced in that subgroup of patients. Now, post-infectious irritable bowel syndrome may have another course. Sometimes this is followed by a persistent overcolonization of the bowel with bacteria. So what I'm showing you here on the top part of this slide is a normal distribution of bacteria in the gut. We all have bacteria. We have millions and millions of bacteria. Most of them reside in the colon, and a few of them in the last part of the ileum. So when you eat easily digestible foods such as rice, by the time they reach the colon, the digestion and absorption is complete, so the bacteria really don't need this or use this food for their own energy sources. But if you have poorly digestible starches such as beans, they get to the colon without adequate absorption, and here the bacteria have a field day using these starches and producing lots of gas. In some patients with irritable bowel syndrome, the bacteria start migrating up to the ileum, and this is a process we call small intestinal bacterial overgrowth, and now they have access not only to the poorly digestible starches, but also the normal starches that we eat, such as rice and flour, and they can start using these to produce gas, and this may result in bloating and symptoms that patients with irritable bowel syndrome often complain of. And one of the ways to prove that this hypothesis is true is to try and suppress the bacterial growth, and this has been done. For instance, in this study, they used a poorly absorbable antibiotic called neomycin, which stays mainly within the gut, and they showed that compared to placebo, there was a significant improvement in symptoms. Now, only a third of the patients responded, which is probably appropriate because we know that not all patients with irritable bowel syndrome have this particular mechanism. Now, one way to treat the bacterial problem is to use antibiotics, but that's not a very attractive option because you really need some of the healthy bacteria, and what an antibiotic does is simply wipe out all the bacteria, good and bad. So in recent years, there's been a lot of attention paid to the use of probiotics, which are so-called healthy bacterial cultures. And this is a study done again in patients with irritable bowel syndrome with two kinds of bacterial probiotics, one lactobacillus, which is the L. salivarius, and the other is the bifidobacteria, the B. infantis. And compared to the placebo, you can see that both probiotics had a beneficial effect on treatment. Here on this axis is shown the clinical score of these patients, and it declines significantly with treatment, but particularly with this kind of probiotic, which is the bifidobacteria. So that's a subset of patients. It's a peculiar subset. It happens in the setting of post-infections. Typically a patient, when I was in Texas, a patient would come up crossing the border from Mexico and say, well, you know, I had an episode of diarrhea. I was down there for a vacation, and I came back. My diarrhea hasn't gone away, or my pain hasn't gone away. And that's the post-infectious irritable bowel syndrome subset. You look at their stools, there's no evidence that they have an infection anymore, but it's still having the same symptoms. But that's a minority of patients, like I said, about 10 to 20%. The majority of patients, we still cannot find any identifiable structural abnormalities in the gut. Yet, when we test these patients objectively, we find evidence of increased pain sensitivity. So this is a classical experiment done about 30 years ago in patients with irritable bowel syndrome. Gastroenterologists love to do these kind of experiments, by the way. They used a balloon and placed it in the rectum of patients with irritable bowel syndrome and normal subjects. And then they inflated the balloon and they asked the patients whether they felt pain. And again, you can see that most normal subjects, shown in blue, really had very little pain, even at the highest volumes. Whereas those patients with irritable bowel syndrome, shown here in red, started complaining of pain early on, even at small volumes. And by the time you reached 100 or more, most of them were in real pain. So this is something we call hypersensitivity. And specifically, we call this colonic hypersensitivity because it's in response to colonic distension. This is a hallmark of irritable bowel syndrome. Now you may say, well, because these patients have psychological problems, then they respond to pain anywhere in the body. In fact, those experiments have also been done. So I told you what happens with colonic distension in patients with irritable bowel syndrome. If you test them for non-GI pain, and one of the ways to test them is have them put their hands in a bucket of ice water and see how long it can stay there, the hand can stay there without them feeling pain, you find that their pain thresholds for that kind of stimulation are the same as normal subjects. In fact, in some studies it's shown that to be better than normal subjects. So these are not patients who are complaining of pain everywhere necessarily. It's specifically the colon that they are very sensitive to. So again, there's nothing wrong with the colon that we can see. So one way of looking at this is the whole, the smoke and fire alarm analogy. So if there's no smoke, maybe there's something wrong with the fire alarm. In other words, there's something wrong with the wiring, and it's going off even if there is actually no insult happening in the colon. So let's examine that. And this is really where we come to the crux of the problem. This is the so-called brain-gut axis. So I talked to you about the little brain in the gut, and I talked to you about the big brain. Where we feel the majority of the problem with irritable bowel syndrome is the way these two brains talk to each other. Now there is some hardwiring that occurs between these two brains. So one of them is through these nerves that go to the spinal cord, shown here. These are the nerves that carry pain impulses from the gut to the brain via the spinal cord. And again, this cartoon just illustrates that. There's a long nerve that goes back to the spinal cord, makes a connection with another nerve, and then this is carried upwards to pain centers in the brain. And today, with the help of modern technology, functional MRI scans or PET scanning, we can actually see these parts of the brain light up under the camera. So we can stimulate the colon, and we can see parts of the brain lighting up. And this has allowed us to really study this phenomenon and study this brain-gut axis in a way that we've never been able to do before. One thing you need to know about pain, and particularly pain centers in the brain, they don't exist in isolation. They don't exist in a vacuum. They're subject to modulation by all kinds of factors. Some of these are childhood factors, some of these are cultural factors, some of these are obviously secondary gain factors, environmental stresses, expectations for pain. All of these factors converge onto the pain center and can modulate the pain experience in a very dramatic way. I want to illustrate that with this experiment that has been done. So this is actually a virtual reality experiment. You can see here is a subject that's been immersed in this machine with goggles on, and what this subject is actually seeing is shown here. It's a kind of a fantastic space voyage kind of film, but the subject actually feels they're immersed and they're traveling. And this is the functional MRI scan of the same subject in response to a painful stimulus. When this subject is given pain in the absence of virtual reality distraction, you can see large parts of the brain are lighting up because this patient is feeling pain. When the same stimulus, the same level of pain stimulus is given to the subject when they're immersed in this virtual reality, they feel no pain or virtually no pain, and the brain itself is not lighting up in those same areas as it was. So just to give you an example of that pain perception is not static. One stimulus doesn't necessarily lead to the same response. There are all these factors that converge onto this. So there's a little bit of distraction to tell you how all these factors can actually modulate the pain experience. Now let's go back to irritable bowel syndrome. Let's look at a few of the studies that have been done in these patients. So one of the first studies showed that compared to the control subjects, this is a cross-section of the brain in fMRI, irritable bowel syndrome patients had much greater activation of their brains. You can see how much of their brain is lit up in red on the right side compared to controls. This is in response to balloon distension of the colon. Further, this is a more recent study, that if you look at how patients with irritable bowel syndrome anticipate pain, so they have their balloon placed in the rectum, you haven't distended the balloon, you're telling them that you might distend the balloon. What happens then is that they don't inactivate the centers involved in pain perception. So again, on the right hand side is a normal control subject, and the green shows suppression of activity in that part of the brain. So a normal subject, when told that you're going to receive a painful stimulus, actively suppresses the pain centers in the brain. Patients with IBS, shown on the left side, cannot do that. It's not in their control. And again, just to reiterate, when you actually distend the balloon, they have much greater activation of those centers, in part because they've been unable to preempt their activation by actively suppressing that region of the brain. Further, these patients with irritable bowel syndrome are very vulnerable to their emotions when it comes to pain perception. So in response to anxiety, anger, or stress, their brains in that part of the region responsible for pain light up like crazy. And finally, just to show you the spectrum of factors that can affect the brain in terms of perception of pain, patients with IBS who've had a history of physical or sexual abuse have even greater activation of that region of the brain. And it's fairly common in patients with IBS, maybe about 20% in some studies. So to summarize what I've just shown you, sensory nerves in the brain of patients with IBS are different than those of normal controls. They anticipate pain differently, they react to pain differently. And this difference in the way they respond may actually represent a change in the way these circuits are hardwired. And one of the reasons that they may have been hardwired are because of childhood experiences. And this may result in the perception of even non-painful events as painful. In other words, a lot of us have rumblings of the stomach, which may not be felt as painful, but if you have a brain which is very hypersensitive, that normal rumbling may be perceived as painful. So we talked about how the little brain communicates with the big brain via the spinal nerves, but there are other ways that these brains also communicate. And one of these is called the vagus nerve. This is a long nerve that originates in the skull and connects most of the upper part of the gut to the brain. This is a very interesting nerve. It receives input from a lot of different structures in the body, and it has been the target of some very interesting therapies. So there is a company that actually puts an electrode around this vagus in the neck and can stimulate it. So this was first approved for treatment of seizures and has also been approved for the treatment of depression. So the point I'm trying to make with this slide is these nerves that originate from the gut and communicate with the brain are capable of modulating the emotional state of the brain. And that's not a surprise. Those of you who have indigestion, most of us who've had indigestion often feel grumpy because it's affecting our emotional state as well as our gut. But this same vagus nerve is only partially sensory. Most of it is sensory, but about 20% or 25% of it is so-called motor. It relays information in the opposite direction from the big brain down to the little brain. And I want to show you an example of that. This was a study done, I think, in the late 50s. And this was a time when IRB approval was not required, and medical students were often the subject of the experiment. So this was a medical student who was brought to the table for a sigmoidoscopy. And the researcher, who happened to be his professor, played a little hoax on him. And as they were doing the sigmoidoscopy, they proclaimed very loudly, in an alarming way, that they just found this big, massive cancer in the sigmoid. At the same time, they were watching the contractile state of the rectum. And as you can see here, everything was going fine. The student was relaxed. The rectum was quiet. And the moment they said, this student has cancer, you can see the rectum started going into spasm, which is not surprising. And then, after a few minutes of that, they took mercy on the student and said, no, it's just a joke. And the rectal pressures came down, of course, and you can see everything came down very calmly. Now, what we don't know about the story is what the student did to the professor after he got off the table. But this is just to illustrate how stress here can actually modulate very quickly the contraction and relaxation state of the gut. And scientists are now discovering the biological basis of that and the chemical basis of that. And one of the factors that is becoming very important is this CRH, or cortisol-releasing hormone, or cortisol-releasing factor, CRF. This is a peptide, it's a hormone that's produced in the hypothalamic region of the brain, causes the pituitary to release another hormone, ACTH, which then acts on the adrenal glands and causes the adrenal glands to release cortisol. So this is a stress response. And the cortisol then, of course, has many effects in the rest of the body. But the CRF in the brain actually activates that same vagus nerve that we just talked about, and that's shown here on the right-hand side. And when this vagus nerve is activated by CRH, it causes a slowdown of stomach motility, so you start feeling bloated, nauseous, and it causes an acceleration of colonic motility via the sympathetic nerves. So you start having the urge to defecate or go to the bathroom. This is a very common symptom, for instance, in students right before their final exams. But the point is this: you don't have to be a patient to experience this. In fact, if you look at anybody, whether they are normal or have IBS, and you see the correlation between stress and the symptoms, there's no difference. So this is a universal phenomenon. This is not peculiar necessarily to irritable bowel syndrome. So currently, this is my working hypothesis, and this is a controversial area, so almost every expert will have their own little cartoon like this, and they'll emphasize different aspects of it. What I've shown you today is that we have this vicious cycle in place. It's not clear where it starts, but almost any point in this vicious cycle you can take and you will close the loop. So let's say we start with the theory that there is alteration in the bacterial content of the colon, as I showed you in some cases. This is going to cause the increase in serotonin. This is going to cause pain and discomfort. This will in turn lead to stress, cause the release of hormones such as CRF. Then this will feed back down to the little brain, cause changes in the motility, cause changes in the immunity. The gut becomes more vulnerable then to bacteria, can't clear the bacteria, and that causes more bacteria, and then the circle is complete. Or you could start with excessive stress and you could close the loop that way. So there are many ways that this loop could be initiated, and in a given patient it's not clear where it starts, but it is a loop. So some progress has been made in figuring out how it starts, and one of the obvious studies to do was a twin study to see if there are any particular genes involved in this, and we know that at least a component of irritable bowel syndrome is hereditary from these gene studies. As you can see here, if you have a sibling with irritable bowel syndrome, the chances are that if this sibling is a twin, if it's a dizygotic twin, the chances are higher than if it's a non-twin sibling. And if it's a monozygotic twin, in other words, they come from the same egg, and identical twins, then the chances are much higher, suggesting that there is a gene that is responsible, or a set of genes or genetic factors. We just don't know what that gene is just now. But it's not just genes, it's more than that. There are also parental influences. So here is a very interesting slide that shows you on the left side the number of visits of children whose parents had irritable bowel syndrome. And in hatched bars is the father, and in the white bars is the mother. So regardless of whether your mother or your father has irritable bowel syndrome, if you happen to be a kid in that family, you're going to visit the doctor at least twice as often as somebody whose parents don't have irritable bowel syndrome. Suggesting that in addition to, and the mother and father suggest that in addition to the genes, there is perhaps a learning component to this. So we've been interested in many of these aspects, and I really don't want to make this a science talk, and particularly not my science, but I did want to show you a couple of slides that illustrate this principle that early childhood may be a critical period for the development of irritable bowel syndrome. So in one of the earlier models that we had developed for irritable bowel syndrome, we took rats which are 10 days old, and we gave them an infusion of a very mild dilute vinegar, basically acetic acid. And then we let them grow up. 8 to 12 weeks is when rats become adults, and we tested them for pain. And we tested them for pain the same way we test humans for pain. We put a balloon in the rectum, we distend it, and we observe the response. And this is what a rat does when you put a balloon in the rectum and blow it up. You get a series of behaviors that correlates with the pain they have, and we can actually quantify that. So when you do this to neonatal rats, in about between 7 to 10 days after birth, and you let them grow up, what you find is the same thing that you find in humans, that in response to balloon distension, their curve is shifted to the left. In other words, this is the control. These are the rats which have had the acetic acid. You will see that they respond much more vigorously compared to controls to the same degree of distension. And interestingly, when you do this in adults, you repeat the same experiment in adults. You take normal adult rats, you give them acetic acid, you can't really induce this sensitization, suggesting that there's something very vulnerable about the neonatal period. And these findings in rats are now being corroborated in some way in humans. So this is a study done on the Swedish National Registry. Sweden is a country which actually has a registry for all births in the country and follows all their citizens. So it's a really very, very fertile place to do this kind of research. What they did was they took about 500 mothers with uncomplicated pregnancies and looked at patients who had functional bowel syndrome, such as irritable bowel syndrome. And they found that if the neonatal baby had had gastric suction right after birth, which is a fairly common procedure, they were twice as likely to have irritable bowel syndrome or functional bowel disease when they grew up, suggesting that, again, reinforcing the concept that during the neonatal period, if you do something that we think is even minor or transient, in some patients, and this may be because of genetic factors, it really causes a permanent change in the hardwiring of their systems. So I'm going to sort of start concluding by going back to this quote for almost 150 years ago, which one of the first descriptions of irritable bowel syndrome. The bowels are at one time constipated, at another lax in the same person. How the disease has two such different symptoms, I do not profess to explain. And unfortunately, I'm not sure I'm much wiser 150 years later. But I may be able to help you with this question, with apologies to Eliza Doolittle, is it all in the head? And that the gain in pain is mainly in the brain. The difference, that there are two brains that we're talking about. Thank you for your attention. I'll be happy to take your questions. It's a very good question, and in fact, in my practice, that's the focus of treatment. There are a couple of ways to do that. There are some medicines that we've used for a long time. Examples of these are tricyclic antidepressants. These have been used, well, they started off as antidepressants, but over time we found that they were actually very helpful for neuropathic pain syndromes. In fact, they're commonly used for diabetics who have peripheral nerve pain. And they act, we think they act on injured nerves and reduce their excitability. So tricyclic antidepressants have been tested in patients with irritable bowel syndrome, and there's reasonable evidence to think that they actually work in low doses, in doses that are not typically used for depression. Newer classes of agents have also been developed for the so-called neuropathic pain, but have not been rigorously tested yet in irritable bowel syndrome. They've been tested more in pain from other forms of nerve injury, but I use those a lot as well. The study found them out by doing community surveys. So they would they would do random phone calls, or they would mail questionnaires and ask them to fill out a checklist of symptoms. And looking at that checklist, they met the criteria of irritable bowel syndrome, but they didn't seek patients. The short answer to that is no. They have tradition. So there is some confusion in the laity about irritable bowel syndrome, IBS, versus inflammatory bowel disease, IBD. It's our fault, Dr. Zerhal, because the first two letters are the same. So inflammatory bowel disease refers to ulcerative colitis, Crohn's disease typically, although there are some other forms, where there is overt inflammation. You take a biopsy, you can see evidence of inflammation or destruction of the normal architecture. And as I pointed out, in irritable bowel syndrome, you don't usually see that. And there may be a subset of patients with irritable bowel syndrome that have subtle inflammation. And at this point, it's not clear whether these will turn out to be a variant of inflammatory bowel disease or atypical subset of irritable bowel syndrome. But for all intents and purposes, what I talked about today are patients who have no evidence of Crohn's disease or ulcerative colitis. It's a completely different subset of patients. There are, very crudely speaking, three types of patients with IBS. We call them constipation predominant, where the majority of the time they will complain of constipation, which means they won't have enough bowel movements a week, typically less than 3 a week, or the bowel movements they have are hard and they have to strain a lot. So that's what we call constipation predominant irritable bowel syndrome. There's another subset which we call diarrhea predominant irritable bowel syndrome. These are the ones who have frequent bowel movement, 2 or 3 times a day perhaps, or large volumes of diarrhea. And then there's a third subset which is mixed. Some days these patients will have constipation and some days they'll have diarrhea. I think dietary intolerances, particularly carbohydrate intolerances, such as that with lactose, or now increasingly we recognize fructose, are fairly common and can mimic all the symptoms that we talked about, particularly the diarrhea form of irritable bowel syndrome. What we'd like to do as gastroenterologists is look for those intolerances, and there are ways that you can actually test for those. It's a simple breath test, for instance, where you can see whether this patient has lactose tolerance or not. And then we put them either on a lactose-free diet, or we give them Lactaid and other measures. And if their symptoms go away, then we call them lactose intolerant. We don't necessarily call them irritable bowel syndrome, although at the onset their symptoms could have been confused with that of irritable bowel syndrome. So that's one component of your question. Now the other question is, even if the well-defined irritable bowel syndrome for which no other cause is apparent, is there a role for diet in the aggravation of symptoms? And of course there is. There are certain forms of foods that everybody has some difficulty in digesting. Beans are a good example. Sorbitol, which is a common sweetener, is another example. And in patients who have irritable bowel syndrome, even minor gas production, which would otherwise have been tolerated well because of the hypersensitivity of the nerves, becomes a big problem. So yes, diet is going to play a role. And then the third component of your question is, for instance, is what does fiber do for diet? What for dietary additions and dietary modifications do? So fiber has been the mainstay of treatment for a long time for irritable bowel syndrome. You know, we used to give our patients a lot of fiber, and they used to complain a lot, and we never used to listen. We just said it was good for you. And then we started doing control studies, and we found that maybe it really doesn't do anything. And in a lot of patients, it actually worsens their bloating. Now, if you recall the slide that I showed you, that there may be excessive bacteria. And when you give these patients fiber, you're really, adding fuel to the fire. There's going to be a lot more gas production, a lot more bloating. So now we know why that happens, and we're not that enthusiastic about fiber as a mainstay treatment for irritable bowel syndrome. Though, don't get me wrong, I'm not saying fiber doesn't have beneficial effects on colonic health, but as a therapy for irritable bowel syndrome, it's not that popular anymore, and it's losing support. Short answer is no. So there is, as far as we know, no problem with the digestion and absorption of food. It's what gets left behind that may be a problem because there may be excessive bacterial overgrowth. But a lot of times it has nothing to do with the nutrient value of the meal. Clonidine is a drug that's been used for hypertension. Some of you might be familiar with that. And it's found that class of agents also acts on nerves and can suppress pain. And clonidine was shown in some trials, at least, to improve diarrhea also in patients with irritable bowel syndrome. So there has been some research in this, and there are, as far as I know, at least one company that is pursuing this class of agents, but it's not approved. Yeah. Laudatazine is a kappa opioid agonist. It is a class of opioids which acts only on the periphery. It doesn't get into the brain, or it doesn't act on the brain receptors, and therefore it is theoretically free of morphine-like dependency and addiction. So it has been tried in a variety of pain conditions. It has been tried in irritable bowel syndrome as well, and the results have been at best modest and not really impressive, and it has never been approved for that reason. It's basically an antispasmodic, anti-diarrheal agent, but it's got a very low amount. Some combinations have a very low amount of an opioid in it, and the combination is important because if you take too much of it, you're going to get severe side effects from the anticholinergic drug, and so it's considered relatively safe. People won't get dependent on it. Buspar is the brand name for Busparone, which is a 5-HT1 agonist, and it is a drug that is used as a relaxant and has been tried in patients with different kinds of functional bowel disease. I'm not aware of any large controlled trials in irritable bowel syndrome, though. It has been used for another form of functional bowel disease called functional dyspepsia. It doesn't really matter. The doses that we use don't affect motility, so it doesn't really, will not typically make constipation worse, although that could be a side effect at higher doses. We use it really for pain, and both types of patients, either with diarrhea or constipation, have pain, and that's what we use it for. They're roughly equivalent. I think if you use low doses, there's no great danger in using them. If your diarrhea is not responding to any other drugs, it's often used by patients and often prescribed by doctors. It's probably about as effective as Imodium. What I was trying to show in my talk was that there's a brain in the stomach as well as here, and it's the communication between these two brains that may be what's important for the development of symptoms. And we don't really have drugs that specifically target that yet. Perhaps the tricyclic antidepressants are acting on one component of that communication, but there is a lot of excitement about drugs that target that chemical I showed you, CRF or CRH. Those are actively being developed by a couple of different companies. And we think that maybe it represents perhaps a very important new way to treat these symptoms that originate in that axis. There is no relationship between IBS and colon cancer. So having the diagnosis of irritable bowel syndrome does not represent a risk for colon cancer. There's no biological basis to suspect that. On the other hand, it may be a good thing, because if you have irritable bowel syndrome and you've seen a gastroenterologist, chances are you've had a colonoscopy. It's like going to a barber, you're going to have a haircut. So you've had your colonoscopy, and if you had any polyps or anything like that, they've been checked out. So actually, patients with IBS are much more likely to have had colonoscopy. So I would think their risk would actually be lower. In an acute setting, if you were to have pain suddenly in another part of the body, it distracts the brain from pain in some other part of the body. It's called a gating theory. It happens at the spinal cord level, and as I've shown you, it happens there. So you forget about your old pain because now you have a new pain, or at least temporarily you do that. But that's not really what happens in real life. Is with chronic pain, you will get stress, you'll get depression. And if you have underlying irritable bowel syndrome, that could get worse chronically. And the third component to that answer is that there's a subset of patients who have both irritable bowel syndrome and fibromyalgia. Fibromyalgia is actually very common in patients with irritable bowel syndrome. About 50% of patients with fibromyalgia have irritable bowel syndrome. And we're just beginning to understand the explanation for that. And we think it may be at the level of the spinal cord. The spinal cord is sensitized. And at the level of the spinal cord, the nerves in the spinal cord are receiving signals both from the skin, muscle, as well as the gut. And both those signals converge on one neuron in the spinal cord. And we think that because that neuron is sensitized, you start feeling pain in the skin and muscle, which is what happens with fibromyalgia as well as the gut. It's a very interesting association. A lot of work needs to be done on that. So you could give people excessive doses of anticholinergic agents. These are atropine-like agents. And you could effectively shut down motility. You could give them excessive doses of opioids, morphine-like agents. You could shut down motility. You could give them some other agents like somatostatin. There are many ways of completely shutting down motility. The question is of doing so safely without side effects and being able to titrate it so you have a balance between no motility at all and excessive motility, because you don't want to shut down motility completely. You can't do that. You can't afford to do that. I showed you a slide which is illustrative of a lot of different studies that are coming out that in some of these studies there is a definite effect of using probiotics. Other studies have shown equivocal or no benefits. So it's not completely clear whether probiotics are effective, or at least a broad mixture of probiotics that are currently being used is effective. There may be certain very specific kinds of bacteria that are actually going to be beneficial. Right now, most of the probiotics that we use are mixtures of different kinds of bacteria, and that mixture may not be as effective. But it's a very, very active area of research, not just the probiotic, but what the normal flora, the normal bacterial content in the colon do in irritable bowel syndrome or other diseases, even colon cancer or obesity for the matter. This is a very hot area of research, and we're actually actively doing that at Stanford right now. That's it?
Thank you
okay.
very much.
Oh, thank you.